Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by Dr. Christina Enzmann, a gynecologist and menopause specialist with MedStar Good Samaritan, and Dr. Rani Kulkarni, Chief of Diabetes and Endocrinology at MedStar Harbor Hospital. Both facilities are in Baltimore, and we are proud to partner with Red Hot Mamas, the leading nonprofit provider of menopause education and support programs in the US and Canada. Did you know that November is National Diabetes Month? So we're taking this opportunity today to discuss the challenges and connections between menopause and diabetes. Our experts will define menopause, as well as the difference between pre-diabetes, type 1 diabetes, and type 2 diabetes. They'll discuss symptoms of both conditions and how to work with your healthcare providers when the conditions seem to overlap. So you'll walk away with some tips to manage menopause and ways to prevent and manage diabetes, plus how to distinguish and live with both conditions. So if you or someone you know is suffering through menopause and has pre-diabetes or diabetes, you're in the right place to gain information and learn how you can improve your health. So stick around, give us a like, let us know you're watching, share this with your family and friends, and ask your questions in the comments below. So first, let's meet today's guest. Dr. Christina Enzmann is a board-certified gynecologist with expertise in menopausal medicine, endometriosis, fibroid management, and minimally invasive surgery. She went to medical school and completed her residency at University Hamburg in Germany, as well as an additional residency at Sinai Hospital in Baltimore. She wants to empower women to conquer their menopausal transition and a positive health milestone and help them enjoy their midlife to the fullest. So welcome, Dr. Enzmann.
Hello.
And Dr. Rani Kulkarni is a board certified in both internal medicine and endocrinology, diabetes, and metabolism. She went to medical school at Gulf Medical University and completed her residency and fellowship at MedStar Union Memorial Hospital. She is committed to helping those diagnosed with endocrine disorders understand how lifestyle decisions impact their health and treatment regimen. Welcome, Dr. Kulkarni. Thank you for joining us. All right, let's get into our questions. Let's start with some for Dr. Enzmann. Dr. Enzmann, we often hear the terms premenopause, menopause, and postmenopause. What are the differences between these conditions?
Great question. So that's my favorite nerd answer. So first, I would like you to know there is a whole worldwide scientific collaboration, and they try to really define these stages in reproductive aging. And these are called STRAW criteria, stages for reproductive aging. And they really came up with very good definitions in terms of clinical symptoms, but also blood work so we know when we study these women, so we know exactly, are we all talking about the same women? So premenopause is really everything that comes before that menopausal transition. Now, most importantly, perimenopause is like this entire time when we transition until we finally in postmenopause. So I think that one term that's most confusingly used is actually menopause. Really, scientifically speaking, the term menopause only determines the date of your last menstrual period. For example, whatever you can say, my menopause was in April 2018. That was the day of your menopause. Everything that comes afterwards is actually correctly termed postmenopause. So actually, I treat postmenopausal women. However, I am relaxed about that terminology. I know it's just much nicer to say we are in menopause and we are menopausal women. So that is okay. And important, so the perimenopause now encompasses these years prior to that last menstrual period, including the 1 year after that last menstrual period. And the reason why this perimenopause is important in certain ways is because that's when women, for example, are most symptomatic, actually.
Thank you very much. I did not know that. Really good information to know the differences between the three. So let's talk about the symptoms. What are the symptoms of menopause?
All right, here I also would like just to explain that there is a myriad of symptoms. There are a couple of most common ones. I'm going to go to these right in a second. However, you have to understand that most our organs and our body systems have estrogen receptors. And that is why when these estrogen levels and hormone levels suddenly first starting to have a roller coaster in perimenopause and then slowly decline, that's why our symptoms can be very variable and can affect many body symptoms. However, the most common is that I hear a lot are the hot flashes. Scientifically, we call them vasomotor symptoms. These are the sensation of having heat and in your head or the entire body. Sometimes it's the feet, and it can be just very mild. You're not bothered by it in any major way, or it can be highly life disruptive. So during the day, we call them hot flashes. If they happen at night, we call them night sweats. Additionally, from these vasomotor symptoms, women often complain about insomnia, so they just can't sleep anymore, even without associated hot flashes. And then typically we have the brain fog. This is when women, particularly when they have usually highly functioning jobs, they feel they can't computerize right in their head anymore. So that's the most typical thing. And later on, once we are long in postmenopause, the low estrogen levels do affect genitourinary tissue, so the vagina and the bladder.
All right, thank you so much. What are the treatment options for menopause?
There are also plenty of treatment options. I start today with hormone replacement therapy because we're going to, explain that a little bit further later. So I'm starting with hormone replacement therapy because it is still the most effective therapy for symptomatic vasomotor symptoms. So for women who have terrible hot flashes, the hormone replacement therapy actually works the quickest and the fastest. However, there are other options. In hormone replacement therapy, we're going to explain later who's a good candidate. There are, however, also many non-hormonal treatment options. And these are medications that are type of medications we used to use for depression or pain symptoms, and in very low doses, they can actually be also very effective for vasomotor symptoms or hot flashes. Then, and we are going to discuss that particularly today, lifestyle changes can be much more effective than you think, and particularly focus on sleep, stress management, blood sugar stabilization, and exercise. And we are going to reiterate this a couple of times during this talk.
Perfect. Thank you so much. Appreciate you talking through the different types of menopause, symptoms, and treatment options. I'm going to turn it over to Dr. Kulkarni to talk about diabetes. Can you talk about, let's start with insulin. Can you define what insulin is? That's something that a lot of times when you think about diabetes, you think about insulin. Can you talk about insulin first?
Yeah, so insulin is actually a hormone, which it consists of 51 amino acids. It's secreted by the beta cells of our pancreas, which is a glandular organ, leaf-shaped organ that sits just behind the stomach. There are many physiological functions actually of insulin, but the most important one is to turn the sugar from the carbohydrates in our food into energy. So it moves the sugar into the cells of our body and turns it into energy. Any excess amount of sugar is pushed away into storage by insulin. So that's the major function of insulin in our body. And then you have the synthetic insulin, which is the insulin that's synthetically produced for treatment in lowering the blood sugars.
All right, thank you. So let's talk about the different types of diabetes. Can you talk about pre-diabetes, type 1 diabetes, and type 2 diabetes?
Yes, so pre-diabetes, since it's it's self-explanatory. It's pre-diabetes. Early phases of type 2 diabetes can be in pre-diabetes, and that can happen for 5 years to 10 years. And a lot of times it goes undiagnosed. 1 out of 3 US adults actually has pre-diabetes and doesn't know about it. Unfortunately, our current testing does not easily pick up pre-diabetes. And I'm talking about going back to the mechanism of when we consume food, we have that turn to sugar in our blood. Frequent or excess spikes in blood sugar lead to excess or chronic elevations in insulin levels. And this process is highly inflammatory, and a person can live with this undiagnosed and without symptoms for a long period of time. This is the condition of prediabetes. And as this metabolic process or disease process progresses, it leads to type 2 diabetes, which is now a large, heterogeneous, very complex disease that has multiple defects. Some of those defects we know nowadays are at the level of our kidney, whether we are producing enough hormones called GLP-1 hormones that are secreting insulin appropriately on demand or not, level of insulin resistance at our fat cells, our muscle cells, our liver, and now kidneys. So a very complex heterogeneous disease is type 2 diabetes. Type 1 diabetes, however, is when the body just doesn't have any insulin and the person needs insulin to stay alive. And this is primarily a defect at the level of the pancreas. So the most common condition is autoimmune diabetes, also called juvenile diabetes, because it's diagnosed mostly at a young age. It can also be diagnosed later on in our years. It can be called LADA, or latent autoimmune diabetes of the adult. Autoimmunity is primarily the cause. It can also be seen in people who've had recurrent pancreatitis from alcohol overuse, or genetic conditions, or injury to the pancreas, or surgery. And that would be also in the same bucket as type 1 diabetes.
Okay, thank you very much for explaining the difference between those three. Can you talk about the symptoms? You mentioned pre-diabetes, you might not have any symptoms. Can you talk about symptoms of type 1 and type 2 diabetes?
Yeah, so pre-diabetes, you may not have symptoms, or it may be easily missed. So some people do have some subtle signs of insulin excess, which is basically insulin resistance. And that could be weight gain, it could be like the abdominal fat, it could be maybe picked up on physical exam with some darkening of the skin at the creases of your neck or armpits or groin. It could be, like Dr. Enzmann mentioned, maybe some brain fog, difficulty focusing. There can be some people during that phase of 5 to 10 years of prediabetes, unfortunately, with it being an inflammatory condition, may also present with neuropathy, which is basically numbness or tingling or pain in both feet. So that's basically inflammation of the lining of our blood vessels with retinopathy or bleeding at the back of the eyes. So they may have some subtle signs that can be picked up on physical exam. But as prediabetes progresses to type 2 diabetes, then the person may, with excessively high sugars, could have symptoms of dehydration, dry mouth, frequent urination. They may have blurred vision, and some people, unfortunately, adapt to the high blood sugars, may bypass these symptoms and then present with heart attacks and strokes.
Mm-hmm. Okay, thank you very much. What about treatment? Can you talk about how diabetes is treated?
So type 1 diabetes, that's, you treat with insulin. That's pretty much, the best way to treat it. If they have requirements for insulin, it's going to be physiological type of insulin treatment, which is both the long and the short-acting insulin. In type 2 diabetes, with it being a heterogeneous complex disease, it's a very individualized treatment. It's like not one shoe fits all sort of treatment, but primarily we aim at reducing the insulin resistance. So lifestyle therapy would be the foundation for all. Metformin and now more recently GLP-1 agonists are some great medications to help improve insulin resistance. Lifestyle treatment is across the board, whether you have pre-diabetes, type 2 diabetes, or type 1 diabetes, or if you don't have diabetes.
Yep. Okay, thank you so much. So just want to pause for just a minute just to welcome our newer viewers. If you haven't already written us a comment, please ask your questions, give us a like, let us know you're watching. We are here today with Dr. Christina Enzmann, a gynecologist and menopause specialist at MedStar Good Samaritan Hospital, and Dr. Rani Kulkarni, Chief of Diabetes and Endocrinology at MedStar Harbor Hospital. We're talking today about menopause and diabetes. So we've talked so far general questions about what is menopause, the difference between perimenopause, menopause, and postmenopause, symptoms and treatment options. And we also talked about diabetes, pre-diabetes, type 1 and type 2, symptoms and treatment. So I'd like to move next to talk about hormones. We're going to talk about what hormones are and how they affect a woman's body. But I first wanted to start, I'm going to ask Dr. Enzmann a question for you about hormones in general and menopause. So what happens when someone goes into menopause? You mentioned menopause is technically the day that your last period, correct me if I'm wrong, or the day you stop your menstrual cycle. What is actually happening in your body? I know it's hormone related, but do you just stop producing hormones when you go into menopause? Can you talk about that a little bit before we get into hormones a little bit more?
I'm glad you're going back there. Yes, we didn't really go into this. So basically the menopausal transition is really, it's ovarian aging, right? Usually our ovaries, who release every month an egg as we are younger and still in full reproductive potential, they produce our estrogens and progesterone, and they are on a little dance with our hypothalamus. That is like an area in our brain that kind of stimulates the ovaries to make less or more. And all this is also regulated by the amount of eggs we still have in our ovaries. So we never run out of eggs, but they basically age and undergo, we call it programmed cell death. So once you're 40, even there might still be 1,000 left, they're just not doing their job anymore. And that's when the ovaries slowly, give up producing hormones. However, now the important thing is in perimenopause, it's not just that these hormones slowly decline. That would make it very easy. That's not how it is. Basically, first comes this erratic back and forth with the regulator, the hypothalamus and the ovaries. So the regulator is like, well, you're not working hard enough, and it's slapping more stimulating hormone, and the ovaries are, oh. So we have often I call it the roller coaster of hormones. And that's why this perimenopausal transition is often the most symptomatic. We know, so these vasomotor symptoms, these hot flashes, are kind of the worst when this hormone that is trying to slap the ovaries is rising and working hard while the estrogen levels are actively dropping. That's why some women actually also while they're still much younger, might have occasionally hot flashes during their monthly cycles, just saying. So that's the perimenopause. So, and that is the reason this up and down with the hormones. So once then slowly, as we are, 12 months after our last menstrual period, then we are actually officially, per definition, in menopause. And the hormones are not immediately, just flat, and then they do this little thing until 5 to 10 years into postmenopause, they come down to a stable level. Did that answer your question?
Yes, it does. Thank you so much.
When you get me going, I'm just running.
I appreciate that, and I appreciate the explanation, and it makes sense. It's two different areas of your body kind of figuring out what the heck is going on, and they're kind of fighting each other almost. It's work harder, and then eventually you reach this stable level. So let's talk a little bit more about what hormones are. Dr. Kulkarni, I'm going to ask you, what are hormones and how do they affect on the insulin side, and how a woman's body responds to insulin?
So hormones are little chemical messengers. They actually travel all through our body. They're secreted by glandular organs, sometimes just by other parts of the body organs, and they talk to each other. And it's under the control of a very intricate feedback mechanism. When there is any dysregulation in this feedback mechanism, this is an endocrine disease. So there are more than 50 hormones in the body, and that's, insulin is one of them. The sex hormone levels are one of them. Um, the hormones that we go through with the transition in menopause, how it affects our blood sugars are still sort of in debate. It has been shown to raise maybe potentially blood sugar levels, and Dr. Enzmann will be talking about that, like what we can do to help regulate. It's also been shown that women or people with really uncontrolled diabetes also suffer more with any sort of symptoms. So maybe menopausal transition could potentially be more painful or just a lot more harder to go through with uncontrolled diabetes. So there's a very close, intricate relationship. The hormones which we deal with more specifically with when we're seeing patients with uncontrolled diabetes and just very hard to control, we would be focused on cortisol stress, which is a stress hormone, or excessive growth hormone. These are very rare tumors, but this is something that we potentially might try to investigate in a very unusual patient that's presenting more rapidly with onset of diabetes.
Okay, thank you. We're going to talk more about hormones in just a minute, but I have a question from our viewers. This is from Stephanie. Stephanie, thank you for your question. The question is, what if you, so I think I'll send this to Dr. Enzmann. What if you had a partial hysterectomy, so you no longer have a period? When would you find out that you're in the menopause process? So I guess what stage would you be in that we talked about earlier?
Great question. Thank you for that. Yes, you're perfectly right. If you have no uterus, you don't have this menstrual cycle as a help. So I want to say your average menopause age in the Western countries is 51, 52. So that's average. Some women, do it much earlier. So everything is considered normal once you hit age 40. Between 40 and 45, we call it still early, but not premature. So early menopause after 45, just regular age menopause. And then, the upper end, I would say, once someone is still having menstrual cycles at age 58, I would kind of try to figure out what's going on. It doesn't mean that it cannot be still normal in some women, but yes. So when you have no uterus, then I would say, well, at around that time, between 45 and 52, if you start having hot flashes, that is for you the sign that your ovaries are now slowly decreasing their function. So partial hysterectomy, just for everyone who listens, means only the uterus was removed, not the ovaries. So that's what we usually do in younger women. We always try to leave the ovaries behind so they don't lose their hormonal function, right? They do lose their reproductive function because the uterus is gone, but the ovaries are there. So yes, so these women, we go by symptoms, and if you want to know for sure, there is actually blood work, right? So we can measure that hormone that comes from the hypothalamus, the one that's the whip, right? That's trying to select the ovaries, the follicle stimulating hormone. So once that has been over 30, you are officially in menopause.
Okay, thank you very much. I have another question from Stephanie. Thanks for the other question. I'll send this one to Dr. Kulkarni. This question is, what provider would you recommend to treat a female who has type 2 diabetes and could be approaching menopause? So would they go to their GYN? Would they go to an endocrinologist?
We work shoulder to shoulder with this. So,
okay.
She would definitely need treatment for type 2 diabetes. And I would send my patients to Dr. Enzmann to understand more about the transition of menopause and get the right treatment for hormone replacement therapy.
Perfect. Thank you so much. Keep your questions coming. We have some more questions for our experts, but if you have any, please post them in the comments. We're going to go back to our discussion about hormones. Dr. Enzmann, I'm going to kick these to you, but Dr. Kulkarni, if you have anything to add, please do. The question is, how do hormones affect how a woman's body responds to insulin, and can hormone and insulin levels change?
Yes, great question. And that is, with that question, I'm going to open up this entire Pandora's box. That the message that me and Dr. Kulkarni are having for you. So what can you do? So basically, first of all, let's say one hormone is, stress. Stress is, you might have heard this, is correlated to the stress hormone cortisol. So if you have stress, your cortisol level rises, and that affects your insulin resistance. Basically, that is going to increase your blood sugar. The second step is sleep. Sleep is so important. Sleep, you might have known or heard it, is related to the sleep hormone melatonin, but that shuts aside. So there are good studies that show that only one night of poor sleep are going to affect your blood sugar for the next 3 days. Take that in. So, and then the next thing is growth hormone. So that's the hormone that actually, when you exercise, that makes your muscles grow. That is not a good hormone. You actually want that because that does lower your blood sugars. And then estrogen actually does, so as estrogen decreases, does affect the insulin sensitivity. So again, it's going to raise your blood sugars, meaning when your estrogen levels declining, you are going to be more sensitive to carbohydrates. So meaning, even your healthy carbohydrates that you might have been eating all the time, suddenly you're going to have mid-body weight gain, which is the typical fat distribution of insulin resistance. And that's what my patients are saying. They're like, I'm eating exactly what I've been eating all my time, and suddenly I'm having this belly bulge. That is the decreasing estrogen levels. So you have to be careful with the carbohydrates and balance with lots of greens and veggies. And then the last hormone I have on my list is thyroid, right? Most of the time, I have to say, in my practice, everyone always hopes it's the thyroid because then you have like a reason what's going wrong. Usually the thyroid is not the culprit, but yes, it can. And it's also going to affect your lipid levels, your metabolic health, and your insulin resistance.
That's perfect. And can I chime in? That was perfect segue into what we need to talk about, which is the insulin resistance and the highly inflammatory state that we go through undiagnosed for a long period of time. And then we're talking about adding menopause and the decreasing estrogen levels, increasing male hormone levels, which is another atherogenic or pro-inflammatory state leading to cardiovascular disease and strokes down the road. So it's very important for a woman to know that if I've had all the risk factors for cardiovascular disease during my younger years going through menopause, I really have to be conscious about decreasing or eliminating any modifiable risk factors to prevent any cardiovascular risk down the road.
Makes sense. Thank you so much. What if, Dr. Enzmann, you mentioned the belly bulge. What can women do about the belly bulge and weight gain if they have menopause or endocrine challenges?
Basically, everything that helps to lower the blood sugars and stabilize blood sugars and doesn't give you blood sugar spikes. Before I tell you exactly what that means, I wanted to just emphasize something again, and Dr. Kulkarni kind of mentioned it. Even if you are not reaching blood sugar levels or hemoglobin A1C, that is one of the blood levels we draw to diagnose diabetes. So even all these stages before we give you the label, you have diabetes and you're just pre-diabetic, you're already going to have end organ damages. So that can already affect so many organ systems. So I'm trying to tell you, if your doctor tells you, oh, you're diabetic, pre-diabetic, you just watch it. I don't think that is a good approach. That's the moment you want to intervene, and it's reversible. So what to do? So I always say, and that's my personal recommendation to my patients, try to have, whenever you eat, you want to have 80% greens, veggies, nuts, and seeds on your plate. The reason is we call it alkaline. So it's preventing bone loss, it's anti-inflammatory, inflammatory food adds to insulin resistance. and you are going to stay away from other, blood sugar loaded foods. So always greens and veggies on your plate, and then you can have your protein, which can be meat, and then, if you want, some milk products, etc. Very important, you have to stop eating sugar. You have to start reading labels. If it's the sugar in, of course, in your sweet tea or in your muffins, it has to go. There is no other way around it. And then you have to become very careful with carbohydrates. So now think macaroni and cheese, your sandwiches. And I'm not saying you can't have none of that, but it should be, again, looking at this plate, it should be 10 to 20% on your plate only. Then very important, movement. I'm not saying hard exercise. I don't think, a gym membership, when you make it once a week, it's going to make a difference. Really, walking 30 minutes a day is actually enough to refresh these insulin receptors. So if you find time to walk around your block, or you have a way to walk in your lunch break, that is going to make the biggest difference. Whatever you can stick with, or let it be, online videos. You want to build muscle, because muscle is going to take these blood sugar spikes away, because muscle wants that. And again, sleep. Super important for blood sugar regulation. And stress management. I know we all have, stressful lives in midlife for whatever reason. That seems to be just a thing. And you have to make the best effort you can to regulate that, to find ways. And Dr. Kulkarni might mention some, methods, what you can really do, what has been shown to be helpful in stress management.
And what about, Dr. Enzmann, if a patient comes to you saying, I don't know how to read food labels, how should I read them? Can you tell them, forget the food labels, go for foods that don't even have food labels? Don't you think that would be better?
That's a great advice. Thank you. Yes, I assume that in my head. Yes. So you're referring to everything that has a label. In my mind, it's processed food. And even if that's a protein powder, I'm like, don't go for that stuff. This is processed food. You want to stick to the fresh food that you eat like that, or you cook. And yes, perfectly agree. If you need your reading glasses to put on, it's not the food you should be eating.
That's a very good tip. Thank you so much.
And working with a nutritionist actually is very helpful, but then find a nutritionist who is attuned to your cultural background and, is able to adjust to your socioeconomic background. What access do you have in your community? Do you have the right kind of grocery stores? I think it's important to find the right kind of a nutritionist for that. And like Dr. Enzmann was saying, stress management is key and there have been, a good amount of studies, randomized control trials, maybe not as many as we would like, showing that meditation and yoga actually does help reduce stress hormone levels, translating to improved blood sugars and transition through menopause.
Wonderful. Thank you. Those are some great tips. What do you say about all the internet TV promotions that we see for various diet programs that can help improve metabolism?
Well, I think I say save your money, and I think Dr. Enzmann would agree with that. Unfortunately, a lot of these have gotten, airtime because it seems like a quick fix. There is no quick fix for our metabolic health. If we've got metabolic disease, it's happened over time. Our body has it, it gives us multiple chances, just like a rubber band. You stretch it, it comes back, you stretch it, it comes back. But after frequent stretching, it does snap at some point. And that's when, it comes to our attention. So let's try and give our body some time to get back to how it was or how it can be, to its optimal self. You can do this. And Dr. Enzmann has brought some great points to the discussion. Sleep, simple things, sleep, avoiding alcohol and smoking and eating nature's food, making sure you get the movement that every living being needs. All of those, if you manage to do at different levels, different days, they could all be different. But if you just put that on your task list, just as we have on our task list of checking our emails and replying to phone calls. If we put this on our task list, eventually you can be the CEO of your own diet program or weight loss program.
Yes,
Thank you.
I want to add here. I'm going to say what Dr. Kulkarni said. All these fast weight loss programs, you will need your reading glasses to read that small label. So this means we don't want to have that. So it's highly processed supplements. And I wanted to say, again, it's processed, it's inflammatory, and it's not going to address the underlying metabolic health, right? So insulin resistance has to do, our metabolism is not working well, you have high blood fat levels, you have an increased risk of heart disease. So none of this is going to be affected if you are taking a supplement. So that's why you want to, improve that metabolic health, and then you're going to, lower your blood sugars and lose weight. And that, I think, is really the most important thing. And the reason why you get these rebound effects after all, these fast weight loss efforts is, we know it from the gut microbiome study. So the gut bacteria, which you might have heard about it, they're very strong. And we're getting so surprising insights, like what these gut bacteria are really, how many things they really regulate for us. It's like it's a whole entire organ. And unless you change your gut microbiome, your body always wants to go back to whatever weight it had. So you have to change the gut microbiome first. You have to change your gut bacteria, and the best way is to change them by feeding them the right food. And the right food, again, is going to be the unprocessed food where you don't have to read any food labels for.
Thank you so much. That's some great advice. Dr. Kulkarni, what complications can occur if someone has that fluctuating hormonal and blood sugar levels?
So immediate complications from very high blood sugars, the person just doesn't feel well. Those are, it definitely snaps the person's attention. But over time, uncontrolled diabetes, as we know, can damage the lining of our blood vessels in the back of our eyes. We don't have to go through legal blindness anymore if you are on top of your screening annual diabetes eye exams. It could affect the nerves in our feet, or it's called neuropathy, where the person has pain or numbness or tingling, or it could affect the lining of our kidneys, and it can cause kidney failure, which is progressive over time. We have obviously controlling blood sugars, controlling weight, blood pressure, along with medications that have been phenomenally shown to prevent all of these complications. And then, of course, other complications such as heart disease, stroke, metabolic bone health. We know in patients with type 1 diabetes, they have a low bone mass, and in type 2 diabetes, it may affect the bone quality. So all of this are some of the complications of type 2 diabetes. In men, it can cause erectile dysfunction, but we're talking about women today, so we'll stick with the vaginas.
Thank you so much. I have another question for you about treatment. Is there only one treatment for both menopausal symptoms and blood sugar regulation?
Well, is there only, okay, so that's a hard question.
Is there any one treatment? Yeah, is there any one treatment for both?
Probably as an endocrinologist and, treating someone's metabolic health, I would say there is no one treatment. It's always a combination of things. But since we're talking about red hot mamas and we're talking about menopause, and in combination with that, I will say probably what Dr. Enzmann has great expertise on, hormone replacement therapy and lifestyle management. So that's two treatments.
Great. Let's talk about hormone replacement therapy.
Yeah, so I have 1 point. I can put it down to 1 point. What is really going to fix both problems is human blood sugar regulation, stabilize your blood sugars, whatever, and that of course entails now, you have to walk a little bit, you have to eat the right things, but that is actually going to help your diabetes or your insulin resistance, and it's going to help your hot flashes actually. And here I'm going to tell you why. So we knew this in functional medicine since a while. However, there has been a great study, maybe about 2 years ago, where they had two groups of women. The one, both menopausal women, highly symptomatic, And one group continued to eat whatever they were eating every day. And the other group was actually put on a vegetarian diet, and they got some soy extra with every day. And really, the people on the vegetarian diet, they had like 100% improvement of their vasomotor symptoms. The study didn't look at their blood sugars, but I'm sure they improved greatly too. And I know I said they also got some soy to eat. I don't think that had anything much to do with that. The 100 milligrams of soy or 100 grams of soy they got every day. It really had to do with this very alkaline, fresh, and anti-inflammatory diet. So yes, that is the thing you can do for both, for your insulin resistance and your menopausal transition.
Thank you. Regina is asking, can menopause spike your sugar level? I thought that was a good question to answer from our audience.
Yep, it can. And I mentioned that earlier. So it has to do that with the decreasing estrogen levels, you become more insulin resistant. And that means the blood sugars go up. And that's why you're going to start to get the belly bulge unless you really pay attention to what you eat. There's one thing I want to tell you. It's not done with you stop eating. So some people then start skipping breakfast and dinner, and they have one meal a day. That's not what it is, because with that, you're going to stress your body actually, and the cortisol levels are going to raise. And that's also going to give you a belly bulge, the stress hormone. So you want to eat your greens and veggies 3 times a day. You want to feed your body, and that's going to help you with your belly bulge.
Thank you very much. I want to make sure we spend a few minutes talking about hormone replacement therapy. You talked about that earlier. We're getting ready to close our broadcast, but Dr. Enzmann, can you talk about hormone replacement therapy, the current guidelines, how long you're on hormone replacement therapy, and if there's any alternatives to hormone replacement therapy?
Well, thank you. Yes, we nearly missed that important topic. The time was running away. Okay, so hormone replacement therapy by the North American Menopause Society. So basically young menopausal women, meaning they just entered menopause and who are within 10 years of menopause or less than 60 years old. The benefit outweighs the risk. Okay, so if you have hot flashes, you can't sleep, you have brain fog, they are going to be highly effective. Even the main indication are the hot flashes. Contraindications are uncontrolled blood pressure. If you have a personal history of breast cancer and a history of stroke. I'm sorry, I was blanking out there for a second, right? Okay. History of pre-existing history of cardiovascular disease like stroke or heart attack. These are hard contraindications. So they're highly effective and you can use them. So basically after age 60, at that time, the data tells us we probably think the risks start to outweigh the benefits. So at that time, we should certainly consider discontinuing or tapering them down. Most of my patients, I would say after 5 years, I'm like, okay, let's already try. Let's try to get you to a lower dose. And really, in the end, the patient is in charge. If they want to stop it after 2 years, I told them how to wean it down. Most women are successfully able to wean them off. There are about 20% of women that we know about that continue to have severe symptoms in terms of hot flashes. They want to continue on hormones. That is possible. It's no hard stop. I should just make them a note in my chart that we discussed that the risk-benefit equation is not so clear. So just so you know, there's really no hard stop if you're highly symptomatic. But again, I would recommend you try lifestyle changes. Other methods than hormones, absolutely. I mentioned it earlier, there are non-hormonal treatment options. These are medications that usually are coming out of the antidepressant medications, and we use them in very low doses, and they are also pretty effective, actually. One of them would be gabapentin. It's an old-fashioned seizure medication, helps sleep, helps very well with hot flashes. Another medication that actually has FDA approval for that indication is the paroxetine, also called Paxil. In a very low dose, helps with hot flashes. And then herbal supplements, there are some on the market. None of these are FDA approved. You know, I'm always offering them my patients. I've never felt that any of them is really convincing to help someone with severe symptoms. But again, lifestyle changes, highly effective.
Thank you so much. So we're gonna close out our broadcast with some final thoughts, I'm going to start with you, Dr. Kulkarni. What takeaways do you want to make sure that our viewers are getting out of this discussion? We did have a question about mental health as well from Stephanie. What do we do for our patients in terms of mental health as they're going through this process? Anything else that you want to make sure our patients are watching out for that are on the media? There was a question about metformin, which is a dangerous medication. What are you telling your patients about that? Why don't we close out with just some final thoughts from you, Dr. Kulkarni, and then we'll go to Dr. Enzmann. You're on mute. That's okay.
Sorry about that.
It happens. No problem.
I'll answer Stephanie's question first. It's a very important question, and I think that ties into why we have been focusing on sleep and food, and nourishing food, and making sure we avoid alcohol and smoking, and avoiding maybe excessive social media use. So all of these we have seen has improved mental health. So there are different, I guess, environmental exposures, genetic factors, personal behaviors, all of these as a combination have led to diabetes and obesity. So if we are, talking about like, well, I have it in my genes and I have this sentence. No, it's not a sentence. It's a switch that we can choose to either turn on, or keep it off. We as, providers, we're treating patients as a whole. We're not just treating a number. So depending on who we are seeing at the time, if we identify that there are some psychological barriers to personal care, we address that first before we go ahead with any other suggestions and advice. We will not be talking about meal planning and whatnot. We will be addressing the psychological or emotional issues first. So unfortunately, there is a dearth of mental health providers in our, in our healthcare system. But I think this is something all providers should be very familiar with, on how to manage, how to identify people who may need this as priority treatment. Metformin. Metformin, unfortunately, has gotten a bad rap, and frankly, we don't know why. It's been around since the 1950s. It was actually originally derived from a plant, French lilac, and it's been around for so long. It's been established as far as what the side effects are or what the long-term complications are. I've read media reports of it damaging the kidney. It's not true. Only if the kidney function declines is when we adjust the dose down or stop it, just to prevent lactic acidosis, which is a complication, the only feared complication of metformin. It's been shown to help reduce weight modestly. It obviously improves insulin resistance. It's also used for reproductive potential in women with PCOS. It's also, we're learning more about its other, through its pathways, can prevent certain cancers. And so it's definitely a good medication. There are some GI side effects or gastrointestinal side effects, which we can avoid by modifying how we're, advising the patient to take it, make sure they take it with meals, and we can adjust the formulation for an extended release. So metformin is a great medication. It's helped us greatly in our treatment.
Great, thanks for clarifying that myth that we're seeing online about that medication. And thank you for your final thoughts. Dr. Enzmann, anything you want to add to make sure that our patients take away from this discussion?
Absolutely. So first I heard depression and menopausal transition. Yes, so that is actually a thing. There's a clear link between, particularly if we had a history of depression, that often worsens in perimenopause. And please, I'm working a lot to, this is a collaboration between the gynecologist and the mental health provider. So yes, sometimes actually hormone replacement therapy does help, during that time. So please, that is indeed something that it's true. It gets worse in perimenopause, but once that time settles down, the hormone level, things get better again. And then in terms, Dr. Kulkarni mentioned it. So I think it's important that you know these insulin resistant, that is not a curse or your fate. I have patients that come and say, oh yeah, you know, I'm pre-diabetic, my whole family has diabetes, like this is just a road they have to go down. I'm like, no. So we know now, like your genes, you know, you might have not suboptimal genes, but that is really only 5 to 10% of that bill. We know everything else, how your genes work is actually, we call it epigenetics. So most of it, if you're going to become diabetic or not, regardless if you have bad genes, is really affected by your lifestyle. So you can take it in your hands, and it's really important that you start helping yourself, you know, in your as early as you can. Okay, so don't wait until these numbers go up. You can perfectly reverse it. Even if you're deeply diabetic, you can still decrease the insulin need or the need of medication. And in final word to metformin, I haven't read these recent online things, but I do know in obstetrics since a couple of years, we even find it safe in pregnancy to treat diabetes of pregnancy. Just saying. I don't think that's FDA approval for that, but before we start using anything in pregnancy, there needs to be a lot of data that shows it's actually safe. That's it. Get well.
Thank you so much. Really appreciate that. Thank you so much to both of you for the time, the wonderful information. To make an appointment at the Women's Health Specialist at MedStar Good Samaritan Hospital or the Diabetes and Endocrine Center at MedStar Harbor Hospital, we'll add the phone numbers and the links in the comments. But that wraps up our broadcast for today. Thanks again to both of you and to our viewers for joining us today. Appreciate it.
Thank you.
Bye-bye.
Good luck, everyone.